It is a Tuesday morning in the spring of 1973. A man walks out of a state hospital in Illinois with a bus ticket, a 2-week supply of medication, and a referral slip for a community mental health center at an address across the city. The address is real. The center hasn't been built yet. Before we go further, drop a comment with where you're watching from and subscribe if you're new. Now, the state hospital he just left didn't close because community care was ready to receive him. It closed because 4 words written into the 1965 Medicaid legislation made keeping him there a 100% state expense and releasing him a federal subsidy. The community mental health centers promised to receive him. 2,000 pledged, fewer than 800 built. He takes the bus to an address where there is no building. The discharge papers are completed in triplicate. Then the ward administrator signs the last copy, slides it across the desk, and explains that a bus runs from the hospital entrance at 9 and again at noon. The man on the other side of the desk has been here since he was 19 years old. He is 31 now. 12 years is most of his adult life, all of his adult memory of anything outside these walls. The administrator has done this procedure 47 times this quarter. He explains the referral slip and the medication schedule and the follow-up appointment without meeting the patient's eyes. Not from cruelty, but from the specific administrative fatigue of a process that has become routine. The patient asks what happens if the medication runs out before the appointment. The administrator writes a number on the back of the referral slip and says to call if there are questions. The patient folds the slip and puts it in his jacket pocket next to the bus ticket and walks toward the exit. Outside, there are 559,000 people in American state psychiatric hospitals in 1955. The peak year, before the discharge wave changes every number in the system. The state hospital is the largest mental health care delivery system in the country, operating across every state, funded by state legislatures, and functioning as the institution of last resort for a population that no other institution was designed to hold. Its record is not clean. The history of American psychiatry includes decades of genuine abuse, forced procedures, overcrowding, staff violence, the specific institutional cruelty that emerges when a population is entirely powerless and largely invisible. It also includes, particularly in the decade after World War II, genuine therapeutic work, the introduction of antipsychotic medication, the development of ward-level therapeutic communities, the slow accumulation of clinical knowledge about what serious mental illness required and what sustained it. The hospital worked, imperfectly, sometimes terribly, but as the only institution that couldn't refuse admission, because the community alternative didn't exist. It had never needed to exist. Then the fiscal calculus of American healthcare changed, and the patients were discharged into the community that wasn't ready for them, toward buildings that hadn't been constructed, to find their own way to addresses that didn't yet exist. The jail is the asylum's replacement, not the community mental health center, the jail. This is not a rhetorical observation. It is a documented operational fact, measured in patient counts and bed capacity and annual treatment volume. The Los Angeles County Jail provides psychiatric services to approximately 5,000 inmates with serious mental illness on any given day, making it one of the largest psychiatric facilities in the United States by population served. Rikers Island in New York operates a psychiatric unit serving a comparable daily census. Cook County Jail in Chicago has been called the largest mental health provider in Illinois, a description its administrators do not dispute, because the data supports it, and because the alternative description, which is that Illinois has failed to build adequate psychiatric infrastructure for its seriously mentally ill population, and has allowed the jail to absorb the consequences, is accurate and does not require disputing. Approximately 2 million people with serious mental illness cycle through American jails and prisons annually. In 1955, approximately 559,000 people with serious mental illness were in state hospitals. By 2000, that number had fallen to approximately 55,000, a reduction of 90% across 4 decades of deinstitutionalization. The jail population with serious mental illness grew across the same period in numbers that track the hospital decline with a precision that makes the relationship between the two curves unmistakable to anyone who plots them on the same graph. The patients were not cured. They were not successfully transitioned into community care at the scale required. They were discharged from one institution and absorbed by another, one that was not designed for them, and not funded to serve them, and not legally permitted to refuse them. This outcome was not unforeseeable. It was foreseen, documented in congressional testimony before the Community Mental Health Act passed in 1963, raised by psychiatrists who observed that community care without community funding was not care, but dispersal, and overridden by the combination of genuine reformist idealism and fiscal pressure that made deinstitutionalization politically irresistible to both parties for different reasons. The reformers wanted the hospitals closed because they believed, correctly, that many of them were abusive. The state governments wanted the hospitals closed because they were expensive. And the federal government wanted the hospitals closed because a provision in the Medicaid legislation it had just passed made closing them the rational financial choice. The IMD exclusion, Institutions for Mental Disease, was written into the Social Security Amendments of 1965 that created Medicaid. The exclusion prohibited federal Medicaid reimbursement for psychiatric care in any facility with more than 16 beds. The provision was inserted as a cost control measure. Federal legislators did not want the newly created Medicaid program to absorb the cost of the state hospital system, which was large, expensive, and the state's problem. The provision accomplished its stated goal, and it also created an immediate and enormous fiscal incentive for state governments to discharge their hospital populations. A patient in a state psychiatric hospital cost the state 100% of their care. A patient discharged into the community qualified for federal Medicaid reimbursement. The discharge saved state money. The amount it saved was calculable, immediate, and politically attractive to every state legislature simultaneously. Most accounts of deinstitutionalization treat it as a humanitarian reform that was imperfectly implemented, the right idea, inadequately resourced, whose failures were tragic, but whose direction was correct. What they don't examine is the fiscal mechanism that drove the timing, or that the community mental health infrastructure, promised as its justification, was underfunded before the first patient was discharged, or that the institution now absorbing the discharged population is a jail. That is not an implementation failure. It is the policy working as the funding structure required it to work. Picture a conference room in the California Department of Finance in Sacramento, spring of 1969. Governor Ronald Reagan's budget team is reviewing the first-year implementation numbers for the Lanterman-Petrus Short Act, the California law that had established the framework for discharging involuntarily committed patients and tightening the criteria for new commitments. The numbers are favorable. Each discharged patient represents a measurable reduction in state expenditure. The community mental health centers that were promised in the federal legislation to receive discharged patients are underfunded at the federal level, behind construction schedule, and in several counties not yet started. A department analyst raises the question of what happens to patients discharged into counties where no center exists. The budget director has the fiscal answer, which is that the state's obligation ends at discharge, and the federal Medicaid structure determines what community resources are available. The clinical answer, what happens to a person with schizophrenia discharged into a county with no psychiatric services, is not the question on the agenda. The agenda has the savings. The savings are real. The governor has education funding and tax reduction on the other side of the ledger. The discharge schedule is not adjusted. This pattern, discharge schedule set by fiscal logic, community infrastructure funded at a fraction of the scale required, repeated in every state through the 1970s. Reagan would carry it to the federal level in 1981, when his administration converted the Federal Community Mental Health Centers program into a block grant that cut funding by 25% and removed the requirement that states use the money for mental health services specifically. The 800 community mental health centers that had been built, against a promise of 2,000, serving a fraction of the discharged population, lost a quarter of their federal funding in a single budget cycle. Many reduced services. Some closed. The patients they were serving found the community mental health system contracting at the same moment the state hospital system was accelerating its discharges. The medication that was supposed to make deinstitutionalization clinically viable required one thing that the policy did not provide: a system to ensure it was taken consistently. Chlorpromazine, Thorazine, was a genuine advance. For patients with schizophrenia who took it reliably, it reduced the severity of psychotic symptoms in ways that made outpatient living possible for many who had previously required institutional care. The clinical case for community treatment built on this medication was real and was made in good faith by psychiatrists who believed the community mental health infrastructure would be funded at the scale required to support consistent medication management for a seriously ill population. That infrastructure was never built at that scale. What existed instead was a patchwork of underfunded centers serving a fraction of the discharged population, combined with the specific clinical reality of serious mental illness, that the patient who most needs medication is frequently the patient least likely, during a symptomatic episode, to recognize they need it. Consistent medication adherence in the absence of clinical monitoring and structured support is not a reasonable expectation for a population with severe psychotic disorders. The community mental health system that might have provided that monitoring was funded to serve somewhere between a third and a half of the patients discharged into it. The other half found their own way through a community that was not equipped for them, with a prescription for medication that helped when taken and didn't when it wasn't, without anyone whose job it was to notice the difference. The federal funding for community mental health centers peaked in the mid-1970s and was cut by Reagan's 1981 block grant consolidation before the discharge wave had reached its halfway point. Simultaneously, the IMD exclusion continued to operate. Every state retained the fiscal incentive to discharge, and no state retained the fiscal incentive to build inpatient capacity that would have triggered the exclusion. The result was a system with maximum pressure toward discharge and minimum infrastructure to support the discharged, a combination whose outcome the data has documented continuously for 50 years. Picture Pilgrim State Hospital on Long Island, New York, in the spring of 1976. A man is being discharged after 12 years of inpatient psychiatric care. Admitted at 19 following a first psychotic break, now 31, his schizophrenia managed on a medication regimen that the ward psychiatrist has been refining across 3 hospitalizations. The discharge packet contains a 30-day supply of medication, a referral to a community mental health center in Queens, and a bus ticket. The appointment at the community mental health center is 6 weeks away. The medication supply is 30 days. The man asks the discharging nurse what he should do if the symptoms return before the appointment. She writes the center's phone number on the referral slip. He takes the bus. The Community Mental Health Center in Queens is real, one of the 800 that were built. It has a psychiatric staff of 4 for a catchment area that includes several thousand former state hospital patients, plus the undiagnosed and untreated population that the hospital had never served. The 6-week wait is the shortest available. He calls at the 4-week mark when the medication is running low and the symptoms are beginning to reassert in the specific ways he has learned to recognize after 12 years of recognizing them. The line rings. He leaves a message. The callback comes 3 days later. An appointment is scheduled for 2 weeks hence, and he is out of medication in 5 days. The emergency room that receives him 10 days later initiates a 72-hour psychiatric hold, provides stabilizing medication, and refers him back to the Community Mental Health Center with a note recommending urgent follow-up. He is discharged from the emergency room after 3 days. The Community Mental Health Center receives the referral note. His next appointment is in 4 weeks. He has enough medication for 2. He takes the bus back to the address in Queens, where he has been staying. The address is a rooming house. The rooming house does not have anyone whose job is to notice what he does between now and the appointment. The state hospital that discharged him 2 months ago is processing its next round of discharges. The fiscal incentive that produced his discharge continues to operate. The IMD exclusion that produced the fiscal incentive has not been amended. It is still in federal law. It will be in federal law for the next 50 years. Unchanged, unrepealed, continuously generating the same incentive that produced the same outcome in every state that encountered it. Because the political coalition required to repeal it has never formed, and the population most harmed by it is the population least able to form one. Three things disappeared with the asylum that we have not named directly. The first was the institution of last resort. The state hospital, whatever its failures, encoded in its existence a specific social obligation. That the seriously mentally ill were a healthcare population, that their care was a public responsibility, and that no level of illness or social disconnection disqualified a person from receiving it. The hospital was the physical expression of that obligation. Its closure was framed as the transfer of that obligation to the community, to the funded network of mental health centers that would provide care closer to where people lived. The centers were not funded at scale. The obligation did not transfer. What replaced it, silently, was a different implicit policy. That the person in psychiatric crisis is a law enforcement problem rather than a healthcare one. That the appropriate institutional response is the police call rather than the treatment bed. And that the jail, which cannot legally refuse admission, is the institution of last resort that the hospital used to be. We did not debate this transfer. We did not vote on it. It occurred as the structural consequence of eliminating an institution without funding its replacement at the scale the elimination required. The second was the clinical relationship of duration. The state hospital, for all its failures, produced a longitudinal knowledge of its patients, their baseline functioning, their specific symptom patterns, the medication regimens that had worked and the ones that hadn't, the particular warning signs that preceded a crisis for this person specifically rather than for a diagnostic category generally. That knowledge required time in the same institution with the same patient, which is to say, it required exactly what the community mental health system, organized around appointment slots and rotating staff and catchment area turnover, is structurally unable to provide. The patient who sees 3 different clinicians in 18 months is not receiving the clinical benefit of longitudinal knowledge. The patient who spent 12 years in a state hospital was. The hospital was imperfect. The knowledge it generated was real. The third was the honest count. The seriously mentally ill population was visible when it was in the hospital, numbered, budgeted for, politically legible as a group that required public resources. Deinstitutionalization made the same population invisible, dispersed into rooming houses and shelters and street corners and jail cells, where they are counted differently and funded differently and spoken about in different language that consistently underestimates the scale of what the hospitals used to hold. The census that once showed 559,000 people in state psychiatric care now shows 55,000. Not because the population requiring that care has shrunk by 90%, but because the institution that counted them was closed, and the institutions that absorbed them count differently. The asylum is gone. What left with it was the institution's obligation, the acknowledgement, however imperfect, that society owed the seriously mentally ill a place. What replaced it was a jail cell and a referral slip for a building that was never constructed.